Good afternoon, ladies and gentlemen. Thank you for joining us for this this work session of Washington County Public Schools. I'm just going to jump right into it and hand it off to Dr. Savine.
Thank you, Mr. Evans. Members of the board, it's my pleasure to introduce our panelists as we provide an update for Landon's project. First, I'd like to introduce our Deputy Superintendent, Dr. Gary Willow, our Coordinator of Enhanced Programs, Ms. Ashley Park-Browse, and also our Director of Special Education, Dr. Patrick Gravelin, and then Advisory Board Member, Catalyst, and Leader of Landon's project, Mr. Benito Vadalana. As you all know, earlier this year, we opened up and launched the Landon's project that is located at the old Funkstown Elementary School. We provided an update here earlier in the year, and now we're nearing the end of this school year, and we have a number of updates that we'd like to provide to you. At this time, I'll turn it over to Dr. Willow.
Thank you, Dr. Savine, members of the board. It's a pleasure to be here. Really where we're starting with is a slide that you would have seen almost a year ago, the last presentation, the vision of what Landon's project is. There's no changes to this slide, but our hope today is to sort of give you an update of what we've accomplished in that last year, where we hope to go, what our strengths have been, and then also there are areas for us to continue to get better. And we'll talk about that a little bit with next steps. And so with that, I'm actually going to turn it over to Dr. Gravelin.
So our initial work this year is we were able to hire the coordinator for the enhanced programs at Funkstown, Ms. Ashley Park-Browse. So that was one of our first things that we put in place this year. And we had one classroom that opened the very first day of school. It is our enhanced STEP classroom, which is our structured transition education program. And that is for students that are kindergarten through second grade that have cognitive disabilities or cognitive disabilities and behavioral concerns. And so we started out the year with 4 students. We have a teacher and 2 paraprofessionals, and that is where we started this year in that work.
So this year we've been able to connect with our community with more families. In the fall, we were able to host a sensory-friendly trunk or treat for all of our STEP students throughout the county. And so families got to come and experience a safe, friendly environment where they would be accepted for who they are. And then we also hosted a family information night just in January. We had over 30 families attend, where we connected with our secondary transition specialist team to bring service coordination in from DDA, the resources for independence, and our autism waiver coordinator also attended. And so through that, our families got to learn more about what those services are as their children progress through life, and also work on the application process, just because we know that can be challenging and daunting. We have an amazing administrative assistant, and she's been a blessing. She really helped our community partnerships with local churches and community partnerships with Greenwich, St. Paul's, First Christian, and Girls Inc. To really provide more connection for our students within our program.
Our work continued in February. We were able to open our second classroom. So that started on, as you can see, Tuesday, February 17th, and that is our Enhanced Summit classroom. This is for students that are in 2nd through 4th grade that have social emotional concerns and behaviors that are associated with that. We started with 2 students on the 17th. We added our 3rd student the following week, and so there's currently 3 students, a teacher, 2 paraprofessionals, and a social worker supporting that classroom currently, with plans to add an additional student in the next couple weeks. So currently we have 11 students that have been supported at Funkstown enhanced programs this year. One of the students returned back to a STEP program in a comprehensive elementary school. And then we also provided the support for students whose IEP teams determined that a non-public placement was the most appropriate educational placement. And we were able to provide that support while the team was looking for those placements and securing those placements for those students.
So when we think about expansion in 26, 27, in your current Board of Education adopted budget, there are 2 additional classrooms. The STEP classroom, which Dr. Gravelin already has explained, and then a second Summit classroom. This allows continuity then grades kindergarten through 2, and the second class would be 3 through 5. I think it's important, and then we want to make sure that we're clear here on this. Our goal is to partner with our community around this project. It's not meant to be a WCPS fully driven initiative. While we've started this year, and we're proud of the 2 classrooms, we're super proud of the staff and the work that they've accomplished, we know as part of that future work, we need to bring in outside experts. And what I mean by that is, while we bring a strong educational background, what are the best practices as we partner with colleges, universities, medical professionals? And so that is the work that I think is extremely important for our next step. It doesn't matter the number of classrooms. This is bigger than just a WCPS initiative. How do we take what we learn to best serve the needs of our students? Because the needs are intensive. And for us, it's essential that we work with our community stakeholders for this program to be successful. So as we go into the remainder of this year into next year, that is one major focal point that we just have not necessarily got up and running yet. And so that is one thing that we wanted to highlight the importance around that work.
Also in that work is developing more sensory-friendly, non-overstimulating environments and classrooms for our students. And so making sure that there's not too many things on the walls, making sure that furniture is functional for all students' abilities, also modular in the sense that it can be taken in and out of the classroom depending on what those students need. Being aware of the sensitivity to light, sound, all that. And so that's what some of those visuals also support. We are also looking to create a more accessible playground for our students, providing options that don't always have to involve climbing and sliding, some things that are on the ground floor for students that may not feel comfortable climbing. Our students do love swinging, and so that's something that we will always look to provide for our students. But those are just some visuals to kind of show what our environment can look like to support our students.
I get the easy part. So I kind of look at this as our pioneer investor slide. So first of all, I don't get a chance to say this very often, everybody here. Thank you. Obviously, I'm amazed and overwhelmed with where we are today and what the leadership the board's done, and the staff and Dr. Savine for your support to this project. It's amazing from what I'm seeing and where we're headed now. Think about this started 3 years ago. And I call this a pioneer slide simply because people believed in a vision that we needed to help a special group of our community students, and they were willing to step up and believe that it's possible to do something. So the slide shows Landon's Puzzle Pieces is a nonprofit. We started to do just this. So sometimes it's just financial, and so this last year, we gave about $20,000 to invest in the Funkstown School, but over the last 3 years, Landon's Puzzle Pieces invested probably equally amount to other schools throughout Washington County. A lot of that happens in dollars you don't see. So we have an Amazon wish list on our website, and a lot of our clients and community partners and friends in the area here simply go to the website and buy a Century item. It comes to our office, and we've had truckloads actually come to our office, pick up. I have to call them and say, hey, we got a lot of boxes. And I don't know where they go. Actually, they get distributed throughout the schools, and we just really rely on the school to do that. So part of what you don't see in dollars is a lot of the items that have been collected the last 3 years. And it actually goes out to families as well. The Alice Virginia and David Fletcher Foundation gave $150,000 out over 3 years, but this year they literally gave year 2 and 3 up front. They wanted to pay it forward, so they finished their full donation pledge. And the Bowman Foundation has pledged $100,000 over the 5 years. Throughout that, the wish list and other private donors have just, through the Community Foundation, have given us checks, and we are continuing to do that. We're gonna have some fundraisers coming up in the future. It's easy now. I think it'll be easier now because they see where the decisions are made, the progress has been made. It's easier sometimes to step up when something's actually visible and see, and we can rally the community support. So we're going to continue to work on that. We've got some fundraisers coming up. Meredith Park, I'll just share with you, has just launched a special needs room that's going to be designated with sensory friendly at the ballpark. And September 6th is a big special awareness that night. And we're going to, I think Landon's actually going to be throwing out the pitch that day. So we're excited about that. But what's happening, I see, not only with the school, and this is where the partnerships in the community come together, is that we are working collectively together. They're seeing the leadership, they're seeing the conversation of the project, but others are coming along now to be part of the project too. So thank you for everything.
And we're available for any questions board members may have.
I keep seeing, oh, sorry. You're okay, go ahead. I think last time some of the doctors were actually even here, and it's mentioned specifically in here about collaborating with medical partners. So I guess I'm just trying to understand exactly what that looks like. Is it they're giving advice or recommendations for the specific students, or is it for the programs? What does that look like?
It's more for the thought is for the programs, and they're part of the advisory board, but it's not an area that, as I noted, it's a work in progress. While we had good intentions this year, and we've had board meetings, we just have not had the opportunity to finalize truthfully what that all entails. And so that is probably the most important thing. It's why on the future work, we highlighted that ahead of time. It's work that we need to do.
That was my question, but I'll ask a backup one. Where can people at home watching find the Amazon link in case they would like to donate?
LandonsPuzzlePieces.org, or that's really it, and it's a Washington County link. So there's a wish list, a QR code you scan there, and then we're going to set that up now that we're going to set up another process where actually it can come directly to the school for delivery over a period of time as well.
Thank you.
Do we have a link that we could add to our website, Dr. Savine, for that? Is that a way that we could link that up on our website?
We can certainly work with our communications team to make sure that's seamless.
I just have another question. I'm seeing this picture here. I'm assuming that's a concept design for the playground. So what do we have now?
Right now, we have a much smaller playground system. I'm not sure how old it is, but it does have 2 tall slides, a small slide, some climbing steps, lots of ability to climb and slide, not so much just interactive things for the kids, because not all of our kids necessarily want to play with others on the playground, but they still want to be engaged and have fun outside. So really looking at those more ground level accessible.
So what is our timeline for something like this? I mean, this looks really kind of more focused for that type of student. And maybe the one that we have there is left over from an old school. I'm kind of wondering, because I would think that's more dangerous. And these look like they're more, user-friendly. So where are we into?
So we had a meeting last week with facilities to begin the work for planning out. The goal is to have the new playground installed shortly, we think end of summer, but right toward the beginning of that school year. We were able, and again, we want to thank all of our community partners. The recent Fletcher Foundation actually puts that total toward that playground, and we think we're close to where the funding should be for that.
That's an expensive, endeavor for sure. I mean,
Yes.
that was part of a Rotary thing when we did that. So, a project like that is very expensive. So it's good, and I really like that concept that you have. So good.
My question, and I'm sorry, Ms. Park-Browse, I'm going to kind of put you on the spot here, but I don't necessarily expect an answer either. But, you know, you were kind of hired to come with this idea and actually implement it, right? And so, you know, we've got great community partners that come around and are great at bringing resources in. We've got other community partners that are great for the medical side of it that we can't really provide. Now we got to figure out how to put that into an educational setting that will help them go and succeed. And so you are at the ground level of something that I personally feel extremely strongly in, and I'm very, very high hopes for this program. How do you see this looking? You know, what's your vision for, I don't know if vision's the right word. What is your vision for this over the course of the next 3, 4, 5 years, knowing that right now we only have 8 to 10 students, expecting this to grow to be what, 30 or 40 students over the course of the next 5 years?
Yeah, so we are looking to grow, I would say about 2 classrooms for the next 2 to 3 years, which would support 5 students at a time. And then it's really developing an understanding of what that medical model is, and ensuring that, you know, as the coordinator, I bring kind of making sure everyone's together and making sure that we are working towards the same goal. If there is like misunderstandings or certain ideas that I think we need to talk about, then we bring it together and work through those challenges and ideas. I would say, like, I'm a very collaborative person. I don't think my way is the only way. And so to me, bringing in the expertise from others is probably my role. And then making sure that when those experts are out of the building, or making sure that we're continuing with the work.
Yeah, yeah. No, that's great. And, you know, Dr. Gravlin, you kind of alluded to it, right? You said one student did go back into their home school. And so, you know, your goal, unlike every other elementary school in our system, is to have as much turnover as possible, right? You know, so with that being said, I can't imagine you just send the kid back to Clear Spring Elementary and just say, good luck, have at it. So how does that transition look?
So far, we've been able to transition with our staff going with the student to ensure that the staff receiving them understands the strategies. Because you can read something on paper, right? But it doesn't always give the full picture. So having that staff go and support for a couple days, maybe a week or 2 even, to make sure that that student is successful with that transition is how we've been proceeding and how we plan to proceed. And even students that are coming, schools have been sending a staff member who's familiar with them to, again, help us establish that relationship and learn that student.
Excellent.
Yeah.
Excellent.
It's been a very collaborative process.
And I might add to our staff have a lot of different ideas and have asked for additional training. Like, could I go pick up this type of training, you know, X? And so I think the staff there, I want to give them a shout out because, again, there's different concepts out there. Today, earlier, you know, we talked a little bit about the idea of movement, right, and the importance of that. But I can't sit here and say I'm an expert in all those areas. So how do we bring in outside experts to ensure that we're doing best practice? And that could be bringing in, but that could also be by making sure our staff have access to the training that they need in order to successfully meet the needs of our students. And I think, again, I don't want to say that nothing has happened there. It's just as we learn, what we think, you know, when you're starting a classroom or a program and you have great intentions, and then you have to adjust, as with anything that's brand new. And I think that's where we're truly at right now, is an adjustment phase.
How does this program differ maybe or complement what we're currently doing in special ed? And there was something else, maybe I'll think of it, but how does this program complement or differ? What kind of students are we looking at for this program? And then the first part.
So for the programs, we are looking for students that are already within one of our comprehensive district programs within one of our comprehensive schools. And for some reason or another, they're not being successful. And so we're really using this as a continuum of support. With some of it, the hope is that we can help support them, figure out what they need, and then have them return back to a comprehensive elementary school being supported within a district program. Some, it may be supporting the students that as the students, students' IEP teams have determined that they require a non-public education, that we're supporting that student as that process is unfolding. So that they can receive the support, we can provide them the education as that process unfolds for that student.
And I would extend on that, the program with the enhanced programs itself kind of removes some of the natural triggers that are within a comprehensive school. So we have a much smaller environment. It's a lot quieter. There's fewer transitions, fewer environmental disturbances. And so we're able to kind of work with that a little bit more and then help them build those skills by intentionally working in those other moments of support.
Well, I appreciate all the work that you guys do on this project. This is a vision that is going to be very important for our students moving forward. So we appreciate all the work and support that we get from you as well, Benito. So thank you guys.
Thank you.
President Evans, if I may, I just want to extend appreciation to this board for the level of support through the budget process and recognizing the importance of lifting up and addressing the needs of special education.
Significant part is the partnership that the private community can bring together with school board. So open conversation, open dialogue, just understanding the desires of where the private side wants to be there. One thing I'll let you know, we're going to keep elevating the conversation in the community. I think the more the conversation can be elevated, it'll be more significant support to not only the budget and community coming, but we're actually bringing in Temple Grandin, who is a world-renowned speaker in this area, to the Maryland Theater this year. So what we're going to keep doing is doing things as much as we can to bring focus to this in the community. Helps educate us, brings us support, but also brings a lot of attention that could help make all of our focuses a lot easier too. So thank you.
Thank you guys.
Thank you.
He's a good speaker.
President Evans, the next work session topic is a WCPS self-insurance program. I'm going to turn the program over to our Chief Operating Officer, Mr. Jeff Prue. I believe he's prepared to introduce the team that's before you, and we'll engage in our discussion regarding self-insurance program.
Thank you, Dr. Savine. Good afternoon, board members. I'm happy to present today with members of our finance team. Of course, you know Mr. Sisler and Mr. Shives. Also, Terry Baker is here with us, our Executive Director of Human Resources, and we're pleased to have Ms. Sherry Hirschman, Area Senior Vice President for the Arthur J. Gallagher Company, and Christina Price, who's also a consultant with the Arthur J. Gallagher Company. They are our consultants, collectively, you and us, as we administer all of our benefits programs to our family here at Washington County Public Schools. Sherry and Christina, I think collectively have forgotten more than I will ever know in this area. So I joked with Sherry as we sat down. I said, I want you next to me so you can kick me under the table when I say something wrong, and you can correct me. So we're going to walk through this. I'm going to take you through the slides. Clearly, I want the team to interject where they feel they can definitely add value when we talk about different slides. But I also want the board members to feel like they can ask questions at any time, stop us. We want this to be an interactive discussion with you as we work through the program. But I thought it was helpful for you, for our employees, for our constituency, to get a little background on what is a self-insurance fund. I think folks recognize they go to work, they have insurance. What's the difference from a fully insured plan compared to a self-insured plan? But self-insurance is clearly a risk management strategy where we set aside funds to pay for the administrative costs and claims payments of insurance coverage rather than paying premiums to a third party. So for instance, we have stop-loss insurance, and when a claimant reaches a certain value, that is a fully insured program. When one of our employees or their dependents has insurance claims that reach a certain value, the stop-loss insurance kicks in and they pay anything that happens beyond that. That's a fully insured plan. We pay a premium for that to the insurance company. If on a given year, nobody exceeds the set value, we paid that premium, the insurance company takes it as their profit for the year, and we move on. That's what happens in a regular, fully insured medical plan. They set a premium for us, for all of our members, and whether we expend all those funds or not, the insurance company takes them. In a self-insured plan, we only pay the claims and, of course, the administration of the program. So it limits the risk in terms of the profits that we may pay to a third party to manage that coverage. It reduces our administrative costs, and it allows us to have a little more say in the tailored coverage that we want to offer to our employees. There are some limitations to that in terms of what the third party can do and can't do with their own systems. But for the most part, if you're buying a fully insured plan, they go, oh, we have plan A, we have plan B, we have plan C, choose one. We have the ability sometimes to work within that. The cons are that we are liable for risk, just like with that stop-loss insurance. If our claims go up significantly because of the medical needs of our employees and their dependents, we have to pay those bills. And so sometimes that can be catastrophic events that can drive those claims. Overall, how it works, we hire a third-party administrator to process our claims in our current condition and has been now for probably a decade or so. It is Cigna is our third-party administrator. The value of the claims is determined through the TPA network, through Cigna's network. We utilize the Cigna Open Access Network. So they negotiate with providers, with hospitals, with doctors, with pharmacies for services, for products, for prescriptions, and we then pay for the amount, whatever that negotiated amount is. The third party also manages large cost claimants to reduce costs for WCPS. So we ask them to also do some case management, to work with some of our employees and dependents that maybe are undergoing severe medical needs. Maybe we have a special program that works with cancer patients that actually can connect a local doctor to someone who may be across the country but is an expert in the field to make sure that they're getting the appropriate care and that they're following the right standards and protocols. We also can manage, sometimes in a high-cost claimant situation, are they adhering to their medical plan? Are they adhering to the medications and the prescriptions that are provided to them? Sometimes if I'm getting adverse side effects, let's say from a prescription, the desire is immediately to stop without doctor's consultation, but sometimes that can set you back further. So they help to manage those types of processes as well. The premiums paid by WCPS and, of course, our employees are held in a separate fund from the general fund accounts. We call this our self-insurance fund, and we track all that from an accounting basis. You see that when we have our auditors come in annually, but we track the self-insurance fund revenues and expenses separate from the general fund. And then we pay the claims out of the balance of funds in that self-insurance fund, and we offer all three of our programs, medical, dental, and vision, as self-insured programs. We flipped the dental and vision just a couple of years back from fully insured to self-insured. When we look at our claims history, you can look at I've got the last 5 fiscal years here as well as a projection for fiscal year 26. We run our premium year, our insurance year, on the same year as the board's fiscal calendar, so July to June. You see the medical claims, they've climbed from nearly 51,000 to almost 51 million to almost 79 million over the 6-year period. But it's also careful to look at how many lives are we covering. We call that our members. How many employees and dependents are we covering? This includes, when we talk about the total claims, this also includes our retirees that we cover. And you can see the PMPY, which stands for per member per year expense, has risen from 5,865 in the 2020-2021 year to 8,478 projected for the current fiscal year, the current the planned year. And you can see the percentage increase we saw. That value, 2020, 2021 may have been depressed a little bit. That was the year, of course, of COVID, really that started that March prior to the beginning of this plan year. People didn't go to the doctor unless they had to during this period. Let's say if you had an elective surgery, you probably put it off because you were trying not to be in the hospital. So I think some of the increases we've had, if we think about plan year 23 and plan year 24, where we saw 12 and almost 10% increases, some of that is a backlog of some medical claims that were not addressed during the COVID pandemic. The bottom line, of course, is our end of year fund balance in each as of June 30th at the end of each of those fiscal years. So you can see that as our PMPY percentage increased, our fund balance was decreasing. Board policy sets this. We actually have looked at this as 10 times our stop loss, but also as a percentage of the total plan. When we were at 20 and 23 million, we were well above our goal for the self-insurance fund. So we tried to very closely manage plan premium rates for employees to know that we wanted to lose a little bit of money in the plan so that we'd get the fund balance of the plan down, but at the same time, costs started to escalate on us. And so we got in a situation where, as you can see, the planned fund balance is projected to be at a deficit of about $2.5 million at the end of this fiscal year. So a lot of data on their slide. I want to just take a pause here to see if there's any questions.
I have a question. I'm looking at the employee fund balance starting in 2021 at 20 million, and it went to 23. But then I see the 23, 24 at 13 million, and then on 24, 25, we dropped down to 2.4 million, and now we're in the hole. What happened to all that money? I mean, maybe I'm understanding that what you're saying is we didn't raise premiums to counterbalance, and so shame on us for not raising that, and now we're in a negative balance.
Yep. So claims grew at a faster rate than we were raising premium rates. A couple of things were really going on. I think you had some of the backlog from medical claims that didn't happen during COVID. People started to go back to the doctor, so we saw an increase in some claims. We really, during this period, didn't have a lot of catastrophic claims. You also had a rise of several different pharmaceuticals during this period. You have a class of pharmaceuticals called biologics that are very expensive and have capped on and been on the top of our list of most costly prescriptions over this period. A prescription like Humira, for instance, had a handful of members using Humira, but would cost us easily over $1 million annually for just a handful of people. You also, during this period, had a rise of the GLP-1 weight loss medications, and our plan design did not preclude them during this period. You'll see it here on a later slide, but we agreed with the healthcare committee to discontinue the coverage of the GLP-1 medications as of October 1 of this current plan year. But as we got to late in the cycle, as we got to July, August, September of last year, we were spending about $500,000 a month in GLP-1 medications for roughly 400 to 500 members. Those prescriptions were running about $1,200, $1,300 a month per individual. So I think that's a lot of it. And I think I'll turn to Sherry as well.
And that was specific to GLP-1s for weight loss. It just drastically went up. So GLP-1s for diabetes still recovered. We weren't necessarily accounting for those because those are, you need to have those in your plan. If you look at 23 to 24 and then 24 to 25, there's a $10 million jump just in the claims. That wasn't what was, that's what we missed the accounting for because of the claims, to Jeff's point, of really kind of starting to go in and COVID starting to come into play, the people coming into getting services that weren't being done and being held off. So there's that jump right there.
Okay. Move on to the next slide. We want to talk a little bit about drivers of medical inflation. because this is one of the things we tried to keep an eye on, but, again, just the advent of the biologics, things come on the market, but some of that really is covered here. I mean, we should expect that you're going to see a CPI, a Consumer Price Index, increase, but for medical care over the last year, it rose by 3.19%. But typically, we're seeing, in the 8 to 12% range increase in our medical claims. Well, what else drives that? That was something that we had discussion on planning the presentation. Technology improving medical care. As that evolves, the amount of R&D, research and development, that's being done by medical design firms and treatment firms and pharmaceutical companies, that R&D is very expensive. And so as new drugs like the biologics come on the market, they're very expensive. You're starting to see some moves, for instance, in the GLP-1s, where the rates are starting to come down a little bit. And there's some changes now, the pills are out there and not just the injectables, and that may drive some of the costs. There are now biosimilars on the market for the biologics, so that would be equivalent of saying that you have a generic drug for the name brand antibiotic, let's say. You have a generic form of it. That's what a biosimilar is compared to a biologic. And our costs on something like Humira are coming down exponentially because now that there is a biosimilar on the market, doctors don't need to prescribe the Humira. They can prescribe the generic or biosimilar version. Specialty pharmaceuticals, we've talked about new costly prescriptions used to treat chronic conditions. I mean, we see things from time to time that just pop up, or we'll have one of our members that pops up all of a sudden with a medical condition that requires $500,000, $700,000 a year in prescription care, and so those drive our costs. One of the other things, we are blessed to live in an area where world-renowned medical care is within a very short drive to our patients, whether it's down in Baltimore, down in DC, Philadelphia, Pittsburgh. There's a lot of great medical facilities in our region that our members can take advantage of, but they come at a cost as well because those services are also more costly. We should continue to expect 8 to 12% medical inflation in our out years. That's just really where the market is going in this area.
Jeff, I know you're the money man, so you can answer this for me. If we're expecting an 8 to 12% increase, but our projected increase per member is only 3.24, and we're already in the hole, I don't understand.
So the projected, when we look at the projected increase, and I came back to that slide, that 3.24%, that's what we're projecting for the current fiscal year that our increase is over last year. And we're proposing a 10% premium increase for the coming year. So we're trying to pick up some of that. Some of the decrease here is the change in the allowance of the GLP-1 weight loss medications for employees and their members, their dependents, who are not prescribed based on a diabetes determination. So we are seeing, a little bit of holdback in the claims in the current fiscal year because of that change. Our prescription drug claims are actually trending, flat to down a little bit, where we're seeing last year prescription drugs were up and medical was flat. This year, I think we're seeing a little bit of the opposite, but we are holding some of that back. And so to your point, that actually drives us to the next slide. I wanted to talk a little bit about our WCPS plan design. We offer 2 plans to our employees. Each of those plans has an individual and spouse, as well as individual and children and full family plans. What you can see as we look at this, sort of the center column, the WCPS limited plan, what we're looking at right now is the plan we call our limited plan. It's an HMO type plan, and we're comparing to Gallagher's K-12 national benchmark. And I want to walk you through this one step by step. And I think I'm actually going to start at the bottom maybe and kind of move around this slide a little bit. Towards the bottom, we talk about copays. I think most folks are familiar with your copay. You go to the doctor and I have a $20 or $30 copay. I make that payment and, the doctor treats me, and unless I have any other services, I walk out the door. That's the copay piece. The rest, the balance of that cost for that doctor's visit or that prescription is billed to the plan. Moving back to the top, we also have deductibles built into the plan. So if I am having some blood work done, or I'm having an x-ray, or I need an MRI, I have to meet a deductible. So I would pay the deductible. The deductible here shows as 100 for the individual, 200 for family plan. And once I meet the deductible, the insurance plan pays the rest of that cost. Out-of-pocket max is the amount of, actually, I'm actually gonna jump around. I probably should put these in better order. I'm gonna go to the co-insurance. After the deductible is met, that's the amount of the remaining part of the bill that I pay. In our current plan, we are zero. So the insurance plan pays the rest of that bill. So if that x-ray is $500 and I pay the $100 deductible, the remaining $400 goes to the plan. If that had a percentage, let's say, of 10% if that had a co-insurance of 10%, then I would pay, let's say, 10% of the 400. I would pay another 40, and then 360 would go to the plan. And lastly, you have out-of-pocket max. That's the maximum amount an employee is going to pay for their care or with their dependents at $1,000 or $2,000. So all my deductibles or all my co-insurance added up, but when I hit $1,000 or $2,000 for my family, we stop paying medical bills and the insurance plan pays the same. When you look at our comparison to the national K-12 benchmark, our plan is very rich. At deductible of $100 or $200 compared to national K-12 benchmark of $1,500 to $3,000. Same thing with the out-of-pocket max, $1,000, $2,000 compared to $4,000, $8,000. What this means is more claims are hitting our plan as opposed to being born out of the wallets, let's say, of our employees. The co-insurance, ours is zero, the national benchmark is 20%. So one of the ways you can reduce cost is we can look at overall plan design. Similarly, the other plan we offer, which is a PPO plan, we call that our standard plan. Same data here on the screen for deductibles, out-of-pocket max. Again, the same analysis happens on this slide as did the last, that our plan is richer than is the national K-12 benchmark. And so maybe there's some room to work in both of these plans. As we look at combating our increases, there's a couple things, and probably I should have put it on the slide, but I want to make note of this. First and foremost is working with our benefits office and working on programming to help our employees be the healthiest of them they can be. Because if they're the healthiest them they can be, we save claims for the entirety of the self-insurance plan. So for instance, as we reviewed third-party administrators last year, all of the third-party plan design, plan administrators offer wellness funds as part of our plan, comes out of our, it's almost like they charge us for administrative fees and then they give us a little money back. And so we utilize those wellness dollars to support wellness activities, wellness programs, to support community events that promote wellness. So whether it's the Hub City 100 Miler or whatever it's called, I'm probably using the wrong name, or Muddy Mama's, event, which, focuses on, it's a one-day physical fitness sort of agility course, or we've done Color Splash 5K or any number of things. We support our employees by covering the entry fee to get them out and have them be more active and be more well. So we try to use our wellness dollars in ways like that. That's the overarching thing to help our employees be more well. In fiscal year 26, to help our plan, we updated some of our copays for medical office visits to include things like urgent cares and other things. We changed copays for our prescription drugs and raised those a little bit. And of course, we've already talked about the elimination of GLP-1 coverage effective 10/1 for employees that don't have a diabetes designation or diagnosis, excuse me. In fiscal year 27, several of us here represent the Board of Education on the Healthcare Committee with members, representatives of all three of our bargaining units. And one of the plans coming up for a meeting shortly is to discuss the plan design like we just saw in the last two slides. And are there ways that we can control costs in the plan by looking at our plan design so that ultimately keeps our premiums down for both the board and for the employee, but does raise costs for the employees that do use the plan. That's the caveat to that, is we can reduce the amount of expenses that are hitting the plan, but those that are using the plan will see an increase in the cost for their medical care. So it's a fine line there that we have to balance. And I think with that, we are happy to take any questions you have. And I guess look at the team as well, just to check if I missed anything. I also want to make note, Kathleen Boyer is our supervisor of benefits. Unfortunately, when this presentation was scheduled, she already had a planned day out of the office for a personal matter, so she sends her regards, but was not able to be here today, not omitted on purpose.
How does this dovetail with our health center?
Right, so gosh, it'd be 2 years here in August that the WCPS Health Center, run by Marathon Health, has been open. The costs for the health center are borne out of the self-insurance fund. There are no copays for employees to utilize the services of the health center. Health center is open 50 hours a week and has an MD, a medical doctor, as well as two nurse practitioners on staff, as well as a handful of nursing assistants. They can also do blood work right out of that office. They also have a small pharmacy, so regular generic, regularly dispensed drugs are available there at the health center that can be dispensed to save our employees a trip to the pharmacy to make things a little bit easier for them. All of our employees, active employees, and their dependents are eligible to use our health center, which I want to talk a little bit more about the service here in a minute. And from age, Terry, 2 and up, 3 and up, 3 and up, except unless it is a sick visit. So under the age of 3, because of various vaccinations and immunizations children need, a lot of those have they're very shelf stable. So we want to make sure, or have a short shelf life, not shelf stable, but short shelf life. They're not able to do well visits for children under 3, but they can do sick visits for if your infant or toddler is sick, they can do those visits. The design behind the health center is that typically a visit is 30 minutes to an hour, so that the practitioner is spending more time with the employee or the dependent, and they are getting to know them and their health concerns and their health needs and driving them to a better self, a better well self. As we were interviewing with the Marathon team and interviewing some of the candidates for practitioners, some of the folks that were coming out of family physician practice were like, you know, our goal, we are driven to and told our goal is we have to treat and treat in 10 minutes. And so when you think about that, when you've been to, let's say, your family practitioner and you're in and out within seconds, the doctor's in maybe a couple of minutes, checks a couple things, takes a few notes, and they're out the door again. Oftentimes, they are being told that's the most amount of time you can spend in that office. That is not the case with Marathon Health and with our health center. We want our employees to spend time, get comfortable with the practitioners, talk about what their medical concerns are, talk about their family history so that they can treat the core issues. And the reports that we see, we meet with them on a monthly basis. We get reports on the types of visits they've had, how many visits they've had, and the results, and the people that are coming back time and again. Ongoing, regularly, individuals that are using the health center are losing weight to be healthier. They're lowering their A1C, they are lowering their blood sugar, they are lowering lipids. Their blood pressure is declining on a regular basis, vast majority, well more than half are seeing better health out of those visits at the health center. So I think we have a meeting coming up with them to talk more about the nuts and bolts financially of how the health center is doing for us in terms of cost avoidance, right? That's the piece. We're spending this. We want to be avoiding this or more in the health insurance claim from claims at other practices, let's say. So we're working towards that. We've got an upcoming meeting there, but I think the results so far in terms of how our employees are performing by visiting the health center are positive. The reports from our employees of how they perceive the health center and the value they think it brings to our employees is very strong. Very high net promoter scores in terms of the surveys the results that are brought back on all of those visits.
I have a question. This question is directed to Sherry and Christina. Thank you so much for coming. We haven't heard either one of you speak much today, so I'm going to ask you a question. Most companies are in the same boat that we are because we haven't raised our premiums over many years. I've been here for 12 years, and I think we've kind of tried to keep that as low as possible, but I'm sure we're not the only company that has seen the deficits that we're seeing today. What are some creative ways that other companies are trying to support staff, but yet trying to look at the bottom line? So, that we're viable and we continue to be viable, because we cannot continue to be viable at a negative number. So we have got to do some things that we're not relying and hoping that we reach this, something that we're tangibly doing ourselves. So what are other companies around the industry doing for their employees, being creative ways of finding, ways to get the numbers up again?
So I'll start, and I'm sure Christina has a couple things to add to that as well. The first one is the clinic is actually one of the more innovative ideas. There's not a lot of clinics that are driven by clients, and when they do, usually around 2 or 3 years is when they really start seeing that flip the script on that. So being able to kind of push and rely on what the clinic's able to do, because you actually have, it's cheaper, it's a less expensive way to absorb insurance costs is to go through that clinic. Another one is a couple different point solutions. Like there is something that we can bring up on something that where you do compassionate funds, where you help employees try to be able to access some of the funds that are available with the federal government. So they would be some direct things. So that's some of the discussions that we have coming on. The other thing is closing those gaps in cares wherever we can do that, whether it's musculoskeletal and putting in a point solution, whether it's mental health, putting in different types of point solutions. All of those solutions typically have a cost, so we want to make sure that we take a slow approach to it, because you don't want to add costs to the program and then have it not turn out correctly. So there's a lot of things that we can do, but we have to make sure that the cost-benefit analysis is done to be able to put that in place. But I would tell you more and more relying on the clinic, because the clinic does have a lot of things that are available to you. So,
Yeah. So I do like to think about it in terms of small needle movers and big needle movers. So the small needle movers, right, driving care, making sure that the centers of excellence are truly vetted, right? You're not having wasteful costs at providers that may be overly expensive, right? So we use Cigna networks to ensure that we are utilizing the most competitive provider pricing. So things like that are small needle movers. You wouldn't necessarily see the impact overall, but you want to avoid waste. And then some of those bigger needle movers where it's the plan design, and that, I hate to say it, is shifting the cost. When someone has a surgery or a costly condition, we don't want them to not have the care. We want them to access the care. Unfortunately, we do want to shift the cost of it, though, right? So having that employee, see those providers take on a little bit more of that deductible because they're going to be expending more on the plan, and having a bigger out-of-pocket maximum. And then we have seen some more creative plan designs where we're embedding an HRA. So employees have access to employer funds, but they're only going to use what they need rather than having money fly out the door like a health savings account. So those have been pretty big needle movers because they shift the cost pretty dramatically. And then marketing efforts. We've seen that being very impactful, going out to market, getting a more competitive cost from the market, whether it be on a provider side for network discounts or the administrative fees for stop loss and things like that that have brought your incumbent or your current carrier down to a more competitive level. So you're not just eating increases year over year. So those have been pretty big needle movers for us.
On the plan designs, do you find companies are starting to ensure the employee and then decreasing the percentage of coverage for a spouse and family to help offset the cost? Are you finding that? I'm hearing other companies are saying, yeah, we're not going to raise the premium on the employee because we want to take care of our employee, but in a family plan, we may not give them as much as a percentage. Are you seeing that across the board?
Yeah, especially over the past 2 or 3 years, we've seen those family tiers take a bigger decrease in the cost share percentage, especially in the private sector.
Because I figure maybe a spouse, if they got a husband and wife that are working, could get insurance at their other employer. And so of course, it would be easier just to do it under the one that has the most coverage, but maybe we should think about putting the cost back onto the other spouse at their work. I mean, if we pay 85% and the spouses pay 75, I mean, it'd be obvious everyone just goes to 85, but maybe if we drop that for the spouse and the family that it would probably something, I'm hearing that in the industry that that's being more and more used.
We do have a scenario where spousal surcharge, so if the spouse does have access to other insurance outside of the employee's plan, then, the employee is charged an extra dollar amount or extra percentage because the spouse chooses to be on this plan when they have access. It's a little harder to monitor, right? Because how do you ensure that, your spouse does have actual valuable insurance? But a lot of plans have adopted that. And then to your earlier point is the cost share percentage. While we'll pay 10% on the employee only, maybe it's a 50-50 split on that family tier. And that's been common as well.
Yeah, and I think you have to also really look at what other school systems are doing, because schools tend to be the least likely to take that spousal surcharge and put that in place. So, it is something that we hear a lot with nonprofits and hear a lot with for-profit companies. As soon as you go into a school district, it becomes a little bit harder to sell because of the values and things like that are in there and the philosophy that's traditionally in place. So again, just kind of making sure that we understand exactly where to go with that.
Got it. Thank you, ladies. Thank you very much.
Do you see any moves to, so we have the clinic, and I'm thinking if, in a couple years or when the review comes out, it is something that's saving us money. Do you see anyone putting in like an ND, like a more holistic doctor? Because I know that that's something that a lot of my friends and people I know want to go to, but they typically don't take insurance, but they're also less likely to prescribe and do more holistic things. So is that something that could help us offset prescription costs and focus more on root causes versus symptom management with traditional doctors?
And yes, that's one thing that's an advantage of Marathon, is they're able to kind of look at what you need as a school system and be able to expand out the services as needed. But, you have to always kind of keep that in place, because if you don't cover it currently, it's still going to potentially bring more cost to the program. So it's kind of weighing that balance. Does it make sense? Is it going to get somebody, better and more well, or is it going to end up bringing more cost in that program? So it's kind of understanding that and bringing that through.
And I would, perhaps without bringing a doctor that has a specialty in that area, having interviewed Dr. Arnaud, who's the MD at the practice, and seeing her personally myself for my visits, she has that type of philosophy that she wants to get to the root cause. Prescribing that medication is not the first course of action. And I think, to some extent, that is also, I think, a driver for Marathon Health as well. I think they understand that point.
Okay. And then a question about under 3 well visits. I know you mentioned why they don't currently do them, but obviously parents have choice as to whether or not they vaccinate. Is that something that Marathon will not do, or could parents potentially who do choose not to use Marathon for well visits?
They have programs for physical therapy, mental health, urgent care, but we have to grow into those programs to be able to afford to include them. And there could be something for children under 3, but I'm pretty sure when we started working with them, it was a choice based on the vaccination schedule and also the specialists that the pediatrician, what they bring to the table as a specialist for a child under 3.
Sure. Okay.
I'm going to go back to that claims history page on the slides there. I'm just trying to do some quick math in my head, but I'm not as quick as I used to be. So I'm just looking, we implemented the health clinic at the end of 23-24, going into 24-25, correct? Yeah. So with that being said, it's reasonable to kind of show the people watching, right? I don't know exactly what that cost was to implement that, but I'm sure that was a pretty substantial increase. So having a $9.5 million increase in the cost, I'm sure can be attributed to the cost of implementing Marathon, right?
A portion of it. Go ahead.
Marathon is running about $2.2 million a year. I think the bigger cost driver in those years was the cost of GLP-1s. When you're talking around $6 million a year, that's really where the big driver is.
Yeah, because, and that's kind of where my head was going with that. I'm thinking, okay, so you have 6 million there, that's roughly 10% of the prior year, so that would be a 10% increase right there. And then I was trying to figure out where the rest of that was going, and then I see, you know, we have roughly a 500 member increase and then an 80 member decrease. So I'm just trying to look at it, and without seeing the hard numbers, what do you see the benefit being cost-wise so far? It sounds like, and quite frankly, and I'm just going to throw this out there, I really have no interest in getting rid of the health clinic because every staff member that I've spoken to absolutely loves it. They've done a great job. So I'm not interested in getting rid of it. I just want to make sure we're being efficient with it too, because it looks like, you know, when you go and see that increase, and then this year we're projected to have that extra 1.5 million increase, and then, you know, we have a couple less staff, I'm not so sure we're seeing the same benefit that we kind of expected.
So if you think about when you go to a provider, a regular provider, you go to a CVS to pick up a prescription or anything like that, there's always kind of we'll call it an upcharge to be able to see them. The clinic is a straight pass-through. So right then, if you took the clinic out of there, what would this projection be? It's probably going to be more significant than what's showing up there. And it has a lot to do with that pass-through cost. So what, you know, it usually takes about 2 to 3 years to really see it kind of ramp up. And that's right where we're at right now, to be able to see what really is that cost impact for that.
And can I chime in there where when we vetted Marathon, we did put them up against other standalone clinics just to ensure that we were getting competitive pricing. And they do have a guarantee on their ROI to ensure that while they could go to Joe Schmo up the street and Joe Schmo could say it costs $500, they're vetting that cost. They're going to do a market comparison. So the pass-through costs are truly lesser than what you would see on a group health plan. And that's what we hope to, you know, materialize in this next upcoming meeting.
Very good. And then the last question I have is, you know, I don't want to take away, you know, people get their doctors and they like their doctors and they want to keep them. So I got to imagine that of those 9,300 people we currently have in the plan, I'm sure not all of them are going to the health clinic. And I don't want to go and take away anyone's family doctor. Can it be part of the plan design to say, starting next year, all new employees need to go to the health clinic as their primary care?
Yes, it can be long-term gone that direction, but you have a lot of hiring to all of a sudden do. You have to build out a lot more places for people to see. You need a lot more specialists, and then you also need to be able to staff it. And so then does that cost of all of that build up make sense in that situation? It already is incentive to go to this because they don't have a copay. It doesn't cost them to go, and that's the incentive to drive people to go there. And that's a little bit easier than to say you have to go there for your primary care rather than trying to build out this whole entire program, which is going to be very expensive over time.
I would also question, at the end of the day, how are we going to police it? You know, because we don't, you know, for privacy purposes, while we see claims, but we don't see claims tied back to an individual employee because that would violate their HIPAA rights. So I'm not sure we'd be able to police that. While we could put a program in place and a lot of people would consent and just do what they're told, unfortunately, that's not 100%.
I mean, if they're not going to start, I'll just say Joe Schmo, because I do like all of our doctors in this area that I've met. So, but you know, you just wouldn't pay Joe Schmo if that's what Cigna told you that you had to pay. You'd just pay the people at the health clinic. I don't think that would be that difficult, but.
Well, and preventative care is already covered at 100% regardless of where you go. So that's also where we have to kind of worry about because that's an ACA requirement, a CMS requirement. So if I go get a physical, I'm not paying anything regardless of where I go. So there's no way we could actually drive them to the clinic in that particular manner. If they had additional testing, then yes, you could, but it's really that preventive. There's nothing we can do on that.
Okay.
But through our plan design discussions, we can push people to Marathon in other ways
Yes.
than as we talked about in first session.
Bigger delta between the copays.
Okay. Anyone else have anything?
I was just going to say is I keep looking at this plan design, mainly the HMO. When you compare us to the national, we are way, way under. And I think that even if you doubled or what some of these are, I think it's still a really good plan. I would be curious how that would affect the bottom line. In other words, for deductible, instead of $100, you would have a $250 for individual. Instead of $200, you would have a $500 deductible for a family. For out-of-pocket max, instead of $1,000, it'd be $2,000. I'd also be curious to how this plan compares to the county plan. Does the county, they're self-insured as well, right? And do they use Cigna?
I believe they're with Aetna.
Aetna.
I think they're with Aetna.
So, I mean, I know last year it was a question that we asked them about maybe getting together with them and combining our efforts. Is that a possibility? With maybe combining forces to, I see you smiling a little bit.
So yes, you can, but if I'm not mistaken, I think you are much bigger than they are. So you're going to take the brunt of that in a way because you're significantly bigger. I think they have a couple hundred people. Well, like
They're bigger than
they're
that.
like 700-800.
Just to add to the
Yeah.
conversation, also you would be covering fire and rescue,
Yep.
law enforcement. There's probably a difference there in terms
Yes,
of
there is.
cost.
And then and so we do work on, Christine and I actually have a couple groups that have like the county, the schools, the jail and the library that all come together. We also have some that have community colleges that come together. You can do that, but know that the schools typically are the biggest entity in that. And you have the additional risks because you have public works, you have fire, police, depending on if they have jails, things like that come into there. So it looks a little different and your risk profiles could make it up that you are going to take more of a brunt or more of a hit. It could be beneficial. It's not saying that it's not a no. It's just, it's which way does it work?
And I'm glad you explained it because I had somebody reach out to me and send me a message on Facebook and had a list of, doing these things. But I think that it's important that maybe employees know that probably things are going to have to change. We can't continue down the road we're headed, and
I think, Mr. Burkett, I think the start of your original question, this plan actually is our least used plan. Only a small percentage of employees are in this plan. And so, making that move on deductible and out-of-pocket max, while it will help, everything helps, probably does not move the needle. But I would suspect we would if we're looking at plan design, we're ultimately going to be looking at both plans collectively
yeah, I mean, you could
to
do
make
the
some
same
adjustments.
thing. You could do the same thing with the PPO plan and still have a really good program.
I think for additional discussion, this plan is sort of the standard plan. The PPO is sort of our in and out of network coverage where employees have coverage whether they're in the Cigna network or out of the Cigna network. The Cigna network is massive. They're a national provider, so the network is really big. When you're in the HMO plan, you only have in-network coverage. Your risk, your cost is greater on if you happen to fall out of network, let's say for a specialist. That's why most people are in the PPO as opposed to the HMO.
For both of these plans, I see what the national benchmark is, but where are we with like surrounding counties?
You want to talk about that analysis? Or?
So we did do an analysis on where you are with surrounding counties, and the biggest piece is that you guys are a very competitive plan design, and the in and out are too similar to really show that there's a differentiator where you guys are migrating towards trend. Other plans have migrated towards trend where they have a lower cost option added to their plan, such as a high deductible or a deeper deductible or out-of-pocket maximum. And that's where you differ. You guys are still very, very competitive with the two plan options, while others have, opened the door for a lower cost option for employees to choose. So that's what we've found. We can get into the minor details where some co-pays are higher or lower, but you're right in the middle on that core of the plan where it's PCPs and specialists. But it's pretty similar. I mean, it's pretty apparent for that deductible and out-of-pocket maximum that they just have a lot cheaper options. Yeah.
Thank you.
And employees are paying more for the expensive options, and they're just still not as cheap or affordable as yours are. Yeah.
So just to clarify, when we say cheap, like the deductibles are higher.
Yeah.
And you actually have a richer, we'll call it a richer plan in comparison.
And as such then, because the deductible is low on our plan, the premiums are higher because more costs are flowing into the plan.
Thank you very much.
Thank you.
Mr. Evans and board members, our last and final discussion topic is mid-year student success update. It's my pleasure to introduce our team members, our Executive Director of Elementary Education, Dr. Jana Palmer, Executive Director of Secondary Education, Dr. Heath Wilcox, Supervisor of ELA and Social Studies, Mrs. Carly Pumphrey, and Supervisor of Mathematics and Science, Mrs. Amy Seiler.
Good afternoon. Dr. Sovine, President Evans, members of the board. We're excited to share with you today a mid-year update of where we are with student success, sharing specific data in both literacy and mathematics. Before we dive into the data, we did want to talk to you a little bit about how are we supporting student success collaboratively. So as you know, we appreciate the board's approval of high-quality instructional materials in literacy and mathematics. These provide the teachers with resources, with lesson plans for supporting students with grade level lessons, as well as all of the high-quality instructional materials provide additional supports for students who are advanced, students who are lacking particular skills like our multilingual learners and our special ed students. So our high-quality instructional materials are a huge priority for not only providing those, but also supporting students and teachers in using them. So the instructional coaching is our next priority. We have our lead teachers in all of our schools. They serve as our instructional coaches. And we also have department leaders in middle schools who support coaching as well. So coaching is basically on-the-job support. The way we do coaching in Washington County is we work with teachers to analyze data, identify what does the data show, what are the strengths in the data, where are the gaps with the data, and from that, we work collaboratively to identify a goal. What can we work towards? From that, we identify a strategy. What is going to be the best instructional strategy to support achieving this goal? Which goes into the next priority, which is evidence-based strategies. So helping our teachers identify, what is, I just heard most cost-effective decisions. What is the most effective decision to make with the students to help them for, and we'll talk a little bit about those specific to literacy and math throughout our presentation. And multi-tier system of support. That has been a priority. Dr. Sovine has spoken of multiple times. That is just simply a way of how are we providing quality tier 1 instruction for all of our students, as well as the students when they're having difficulty accessing grade level, how are we providing targeted support in both tiers 2 and tier 3. That is something that in Washington County, a really important privilege that we have is 30 minutes of supplemental instruction built into our school day, kindergarten through 8th grade. And that is a priority across in both literacy and math. So our literacy vision that you see here, you've seen multiple times. Every time you've seen me, you've seen this vision. And that is because our vision grounds us in why we do what we do. The most important word is the very first word. All students We know that our families put their students on the bus, their children on the bus, expecting that we will teach them to read and that we will teach them to write. And that is a huge responsibility. Our teachers, our paraprofessionals, our administrators, they work very hard to provide instruction for all of our students. And in Washington County, we ground our instruction in systematic, explicit, foundational reading skills. Also, we provide complex texts that promote thinking and builds knowledge for our students. And our goal is that they will be able to communicate their ideas in the classroom and beyond. In WCPS, our goal is that every student leaves us as a confident and successful reader and writer. So we're going to dive into data. You're going to see data from assessments specific to literacy. In pre-K, this is a new assessment for us this year, the STAR Early Literacy Assessment. MSDE actually provided this assessment for us and recommended it for all pre-K students. That assessment assesses key foundational skills, including oral language, alphabet knowledge, phonological awareness, which is their ability to rhyme, ability to identify a first sound, general basic phonics skills, and oral comprehension. The kindergarten through second grade students are all assessed using DIBELS, and we presented DIBELS data to you multiple times. DIBELS stands for Dynamic Indicators of Basic Early Literacy Skills, and as it says in the title, it assesses basic skills such as phonemic awareness, phonics, oral reading fluency, vocabulary, and comprehension. The DIBELS assessment are short 1-minute assessments that assess the fluent skills in those categories I just described. Teachers can use DIBELS assessment for screening reading difficulties, but also for progress monitoring and to inform instruction. And then the final literacy assessment we give is in grades 3 through 5. It's actually 3 through 12. We're going to talk about the 3 through 5 data in this section. The CAPTI Read Basics, that assessment is 6 subtests, and each subtest is about 5 to 10 minutes each, and it assesses word recognition, vocabulary, which is word meanings, morphology, which is understanding word parts and how those word parts contribute to the meaning, sentence processing, which is context clues within the sentence, reading efficiency, which is their speed and accuracy, and then overall comprehension. So the CAPTI Read Basic gives us what's called a Lexile score, and that score is reported even and shared with families as basically about the level that a student can read a text independently. So all of these assessments, reports are sent home each time we give the assessments to describe the results and to share with families. We're going to now dive into data charts. So the next few slides all have a very similar look. You're going to notice the green is the percentage of students demonstrating proficiency. The yellow is the percentage of students who are approaching proficiency or just slightly below grade level. The red is the percentage of students who are below the expectations. So this assessment specifically is the pre-K early literacy assessment. And you're going to notice that almost 80% of our pre-K students mid-year are right where they need to be. That's really exciting. We have a very strong pre-K program, as you've heard, and that data has been shared multiple times. We do have about 10% of our students approaching and 11% of our students below.
Do we know how these compare to national?
We can get that information. I don't have that right now for the pre-K. Again, this is a new assessment for us this year, and we're still learning how this fits with compared to national. We do get that data for DIBELS, and I can get that to you eventually. I don't have it with me today, though. But that's a good question.
Do you happen to have the information on what the difference between beginning of year and middle of year?
Yes, beginning of the year, pre-K, thank you very much. No, that's comparison of last year. I have the other grades that way, but not pre-K.
That's fine.
Good question, though. Let me get to you all of that information. Okay. Whoops. So DIBELS data, this does show, and I can talk to you a little bit about comparison. Again, this is the assessment we've given multiple times. DIBELS data, we have year over year, and we do multiple school districts give the DIBELS data. And so it is very easy to get the national comparison. And most of the time we exceed the national average. So We currently, in mid-year, almost 60% of our students are meeting the expectations. About 14 are approaching and 28% are below. And Mr. Burkett, this is, in thinking about comparison to last year at this time, this is about where we were last year at this time as well. Very similar to 2024-25 data. Grades 3 through 5, this is the CAPTE assessment. You'll notice in grades 3 through 5, almost 40% of our students are meeting or proficient. And we have 40% approaching and 18% below. You're probably going to notice a pretty large amount in the yellow there. And the exciting thing is we do still have time to get these students at grade level. So they are just below grade level, meaning they are reading. They have skills they are accurate with reading. We need to support them in becoming more fluent and closing the gaps.
But these students were the students during COVID?
Yes, that would still be the students who would be impacted by that. Yep. Okay.
I'm
Yes.
sorry, can I
No,
just-
absolutely.
What I'm noticing here is they start out good, and then by the 3rd and 5th grade, it's going downhill.
Absolutely.
Is there a thought on why that's happening, or?
Well, here's what we do notice, and this is very similar to national data. Students who are not meeting expectations by the end of kindergarten, they likely stay not meeting expectations the rest of their years. And some of our students who are not strongly meeting expectations start to drop. And so, yes, you're exactly right. We have seen an increase in our 3 through 5, though. The good news, last year at this time, we had 32% of our students meeting expectation, and we had 22.6 well below. So we have decreased our well below in 3rd through 5th grade compared to last year at this time, and we have increased to about 40% meeting expectation from last year, about 32%.
And
Yes, Ashley?
I did want to say, I hope I'm thinking of this correctly, but basically all 3 of these exams are actually testing different things. So it's not that we can see what they did in pre-K and they're doing the same or expected the same things once they hit 3rd to 5th. So we might see bigger or better numbers, but that's figuring out their sounds and letters and stuff like that. So it does transition to needing more, the higher grades.
Oh, absolutely, and that is a very good point. And what is expected even in the kindergarten assessment is less than what is expected in the 2nd grade. And by 2nd grade, the comprehension piece has been added. And in the 3rd through 5th grade, we get longer passages, and the expectations grow and increase. Even from beginning of the year to middle of the year to the end of year, the expectations continue to grow. It's a very important point. Other questions about the data, the literacy data? Okay. In addition to sharing the data, our team wants to share specific ways that we're supporting. And I'd like to just kind of paint a picture a little bit of what this would look like. So our grade level teams would be meeting together in a meeting, looking at data. They would have this DIBELS data or this CAPTE data, but they would have other data points. So with our high-quality instructional materials, there is daily assessment. So student work samples. There's also end-of-unit assessments. We have local interim assessments as well. So we have a lot of data points that the teachers would gather together, look at the data, and determine what are our strengths, what are some areas that we need to grow in. So for example, if a 1st grade group was looking and discussing, phonics is really low, and we need to really target that, the team would work together to identify what's an instructional routine that would support that. You'll see these students, these are kindergarten students sitting on a rug with materials. They're basically little letter cards, and the teacher is naming a word and asking them to build that word, and then naming a new word and asking them to substitute a letter. So that routine is called chaining. It's used both in Tier 1 instruction, but it can also be used in supplemental instruction. And we have a variety of resources. We have our reading tutor apprentices. We call them now tutor apprentices because many of them also do math, but they're all trained in reading and they're trained in this particular routine. So when they work with students, the same common routine is used with students, and it gives them extra practice and the same skills that the classroom teacher is doing with them. We also have some reading tutors. We have special education teachers, our ML teachers, all using the same routines with the students, which helps with the common language and just in general, the additional practice for the students. Looking forward, also in supplemental instruction, just to bring that out, the 30 minutes every day is dedicated to targeting very specific learning gaps to improve this data. We also, as a system, want to continue to improve our engagement with families. We know families are an important partner. We know that, again, we shared that we send the data home to our families. We send information about the supplemental instruction that the students are engaging in. We also send the progress monitoring for that supplemental instruction. And we know that we need to improve the support they get at home. What does a family do if their student is struggling? And that's something we want to continue. And really the key to that is ongoing practice. So the best thing that any family can do is to read with their child, especially the books that are being sent home from the classroom, because those are the books that they've been taught the skills. They just need a little bit more practice. And with that, I'm going to hand it over to Ms. Tyler.
Good afternoon. So likewise in math, I'm going to stick with elementary math here for just a moment with you. Certainly in math, we support the academic success of every student through instructional practices and promoting problem solving and reasoning skills. We absolutely believe that every child has the right to be confident and proficient in math. We want all of our students to see themselves as capable of engaging in math and a doer of mathematics. And that will absolutely open doors for their future for them. So that's what we're striving for. The pieces of data that I'm going to share with you today from an elementary math perspective for pre-kindergarten is also a new assessment this year, along with the one that Ms. Pumphrey described. Interesting acronym here. ProLadder stands for Profile of Preschool Learning and Development Readiness. And new for us this year in pre-K, and it does assess key foundational areas in math through a one-on-one interview process with students, and it includes things like oral counting, naming their written numerals, comparing of shapes and the size of objects, and maybe some basic addition like putting objects together. We will use that assessment 3 times throughout this year, beginning, middle, and end of year with our pre-K students. In addition, for kindergarten, it's called STAR Math Assessment, also a new assessment for us this year. I believe one of your previous meetings you heard from Ms. Longerbeam around the KRA assessment results, and so that was new from the state this year from a new provider, and so that was given in the fall. And so we actually in math just simply picked up the math portion of that assessment and are carrying that same assessment through the middle of the year and the end of year to follow the students' progress in kindergarten. So that one, again, focusing on those foundational math skills of counting, recognizing numbers, comparing, identifying shapes, and some simple problem solving there. So, and the third assessment that I'll share some data around is our Washington County Math Interim Assessments, or you might think of them as kind of benchmarks or checkpoints throughout the year for our students. They are locally developed to align with the state MCAP assessments, and they measure the major work of each of the grade levels or the priorities of each grade level according to the grade level standards that have been taught to that point in the year. So first assessment occurs, for example, at the end of October, early November. That will assess the major work that's been taught to that point. Next one in January, assessing that chunk of information, and then we're coming up on a third one. So when we look at that data, when I share that here in a moment, we'll actually take a look at the average of those interims to date to kind of get a cumulative view of how our students are doing within that grade level at this time of the year. So the same setup as with literacy here, you'll see the green indicating those students who are currently performing at grade level, with grade level standards. The yellow are students who are just below approaching grade level, and then the red, those who are still beginning and need that additional support. So this screen is sharing with you pre-kindergarten and kindergarten data together, showing there that those two together, we have just over 61% of our pre-K and kindergarten students collectively meeting math expectations here at the middle of the year. About 20% are just below and approaching, and then another 18% still needing some additional support to reach those end of year targets by the end of this school year. And as Carly mentioned too, certainly excited that we still have time yet to help those students get to that point this year. The next slide, I smushed together first and second grade, kind of our primary data points here. Again, this data represents our Washington County math interim, taking a look at the major work in first and second grade to this point in the year. So we've averaged the first two together to show that currently we're sitting close to 58% of our students in first and second grade performing at grade level. A little larger chunk there in the yellow, approaching grade level, and about 13.5% there just below. And we're able to use that supplemental math time to help support those students in closing those gaps. And then finally, our intermediate elementary students looking at grades 3 through 5. Again, this is the average proficiency rates for the first two interims to date. And so there we'll see that we are about just under 45% of our 3rd through 5th graders meeting grade level expectations in math. About a third of our students just below that expectation at the middle of the year here, and a 22% below. You've likely noticed a decline in that green section, so I will call that out. That it has been a very typical trend, not just in Washington County, across the state and even nationally in math. However, I don't like to use that as an excuse. We are absolutely working to break that trend. And I do want to just name and call attention that specifically in 4th and 5th grade this year, as compared to this same time and using the same assessments last year, our 4th and 5th grade each have shown about a 5% increase from this time last year to this time this year on these same assessments. And I do want to talk just a little bit about what we believe is causing some of those increases. And part of that is that our math team, in coordination with Dr. Palmer, our school-based administrators, have placed a very intentional focus this year on 4th and 5th grade math as far as elementary mathematics goes, taking a look at that Tier 1 instruction. As Ms. McCusker mentioned earlier, from a reading perspective, the math only builds on itself, right? And so we also have, as I mentioned earlier, I have a deep belief that we want every child to see themselves as a doer of math. We are also working really hard to ensure that each of our educators sees themselves as a doer and a confident mathematician. As such, 4th and 5th grade math these days looks different than when I was in 4th and 5th grade math. And so we have, again, put a really intentional focus there in supporting our teachers in 4th and 5th grade with the math instruction, as well as our students by way of action planning with our principals in their school improvement plans. Through that action plan, really intentionally supporting their teachers with coaching. And so each month we get to work with our lead teachers, and when we're working with the lead teachers in our math session, we are especially focused on 4th and 5th grade, not only on specific instructional routines, but also actually doing the math together with them and ensuring that they can go back and coach their teachers in that, as well as supporting students in narrowing and closing any gaps that they may have in understanding. Likewise, our after-school professional learning that my team has been providing this year has been almost solely focused on 4th and 5th grade math instruction. Again, teachers who choose to come to that, we are doing the math together. We're watching video of some of our Washington County teachers engaging in that through instructional routines and also rehearsing and planning together before they go and teach that next unit. So those are a few things that we do believe is contributing to a 5% increase in our 4th and 5th grade data to date this year. I look forward to our 3rd interim and hope to see that trend continue. In supplemental instruction also, again, as Carly mentioned earlier, excited to have the opportunity for tutor apprentices. We have about 25 of the total who were able to get into math classrooms this year, some of our high schoolers, and specifically we built for them the ability to go out in 4th and 5th grade math classrooms and work with students, primarily work with that yellow, the students identified in yellow, in reinforcing their fluency skills in multiplication and division. We know that taking that cognitive lift off of a child who can recall some of those facts more fluently or who can quickly figure out those facts allows them to better engage in more complex math that then comes later. So we've seen exciting things happening there in the middle of our first year with our tutor apprentices. Similarly, in K through 3, we do have 7 math tutor paraprofessionals who work similarly, many of them with that yellow band of students on foundational math skills and fluency in addition and subtraction. And then finally, just a sneak peek looking forward as to where we are heading in elementary math. As I've presented with you all a little bit earlier in the year, some of the things coming through Maryland's math policy. That has been approved, and so a lot of those pieces are beginning to be implemented next school year, including revised math standards that haven't been revised in Maryland since Common Core. We are excited about that. We believe the revised standards are bringing some additional coherence. Specific to elementary, they have a greater focus on fluency by 5th grade to ensure that students are ready for those more complex math concepts going into middle school. And then as far as engaging families as well, while we have provided our teachers earlier this year, we spent part of our October PD ensuring teachers had the tools to send things home with families to do practice math at home as well through centers and additional practice. We're also in the process, one of our big summer work that we're going to work toward on my team is we'll be developing additional, I'll call it spiraling or distributive practice opportunities over time that will be embedded as part of our 90-minute math block, as well as opportunities to engage families from home in the mathematics that their child's learning with those revised standards. So that's a little insight on what's coming.
Could I just ask that?
I'm sorry. Go ahead.
I was just going to say, I think Dr. Zetmeyer asked for the beginning of the year data for literacy, if we could also get that for math. And I don't know if it's possible, but to get pre-K data separated, but not just have pre-K and K together for the math, that would be lovely as well.
I was just going to say that as I've been in the schools, one thing that I hear is that there's a really big increase in special needs students. Do you think that's also adding to this the lower numbers that we're seeing in some of these areas?
Well, we do have the data. Our special education population is definitely increasing. And yes, they come with very specific needs. And that is an area that we have been focusing on in terms of how do we support them in the general education classroom, as well as provide that targeted support with the intensive intervention. So the answer is yes.
I just want to make sure we're not blaming teachers,
Oh,
because
no.
there's also an issue at home. We know that home life for many of the kids is not the best. There's little follow-through. So even though you send stuff home, it doesn't mean that it's getting done at home. So anyway, I just didn't want anybody to think that it's a teacher issue.
Oh, absolutely. Mr. Burkett, because of our teachers and their tireless work, they dedicate a lot of time and energy, and they provide the support for our students. Yes, absolutely.
I just wanted to know, is it normal that literacy and math are basically about the same percentage-wise in elementary school? Because it looks like I'm looking at all of the data presented and it looks like it's about the same.
So again, a point you brought up earlier, they're different assessments too, so that's just important to keep in mind. So the literacy assessments are nationally normed assessments that are used as screeners, and they assess comprehensive reading skills each time. So those phonemic awareness, phonics, fluency, comprehension, and vocabulary, morphology, those are assessed on all the literacy skills. So just to keep that in mind, I would say that yes, we are looking about where, even, and then the MCAP assesses even a different assessment, right? So that data point tends to look a little bit different. Literacy, we excel. And another reason we do that, science and social studies are contents that we don't necessarily have assessment data for, but as our students read social studies texts and science texts and they engage in the work of social studies and science, they also improve their literacy skills. So that impacts it as well.
I'm just saying that it seems like in elementary school, maybe math and English, our students are more understanding, but then it kind of drops off the older they get. But I think once again, it's because it all compounds. So, okay.
I just wanted to say thank you, Amy and Carly, for this presentation. I've been in schools and I've seen the tutoring apprentices, students as well as the paras, and the kids just love the attention and the one-on-one tutoring. It's wonderful. And of course, we know reading and math really go hand in hand. So I think that's one of the reasons why they're similar in the percentages. But it's a great program, and I know you're doing a great job, and we appreciate that. Thank you.
The mid-year data that's generated for grades 3 to 5, is it a one-time event or is it the actual evaluation? Is it one test?
Yes. For literacy, it is the CAPTE assessment. Now, it is one comprehensive assessment with 6 subtests. So each of those areas is a separate test. They give them back to back, but together it makes gives us a Lexile score for the students. Does that answer your question?
The English, the math.
Oh, yes.
Math, different. We're taking, again, because our local interim assessments, how students perform on them do align with how students perform on MCAP. And so in 3 to 5, looking at, and that's taking the average of the 3 interims across the year, because each interim assesses what they've learned to that date, and then the middle interim assesses what they learned in the next chunk of the year. So when we kind of cumulatively look at them all together, gives us a look of that student across the year. So what you have here is taking each child's first and second interim, averaging them together and taking a look if they are above that proficiency mark at this time of year, below, in the middle, or below.
I just had a question to piggyback off Charlie's question. He asked about special ed numbers. It's my understanding that special ed students' IEPs have assessments on them that are specific to the student. Did I understand that they also take the standardized testing? Is that correct? So every student takes this regardless?
The majority.
Okay.
There are a few that for reasons may or may not take it.
Okay, but then if they have an IEP, they could have additional assessments. It would just depend on that. Okay.
Oh, go ahead. So we talk about send the books home for the parents, right? If I'm a parent, I would much rather read Clifford the Big Red Dog or the Berenstain Bears to my first grader, right? What do the math take homes look like?
Yeah, so we are working there to support teachers in sending home. In each of the grade levels, they do centers that help build their foundational math or fluency skills. They're maybe game-based. I could go home and play them maybe with a stuffed animal. I could play them with a parent or a sibling. And so they learn that structure in that game at school as part of their Tier 1 instruction, and then we encourage teachers to send those home to continue practicing that from home as well.
It sounds like we have pretty much an infinite resource for books to send home, do we need more math take-homes like that? I mean, are we well stocked up, if you will, for that, for the kids?
That's a good question. I think, I mean, the resource that we have, our highly quality instructional material, as I mentioned, comes with centers that align to the instruction that's happening in the classroom at that time. The centers are also differentiated as well. So if I'm currently working in numbers 1 through 5, but Carly's working in 1 through 10, I could actually differentiate that way to send home. And so there are a number of options that way. Available in what we already have.
So you're not saying you wouldn't be happy to have more, obviously.
I'll take more. We can look into that, absolutely, and take a look at what aligns instructionally with what we already have in place that they're working on in school as well. That alignment's really important too.
And the last question I have, sorry, is when we look at below, approaching, and proficient, what are the scores that the student needs to be able to attain that specific level? Is it 50%, 60%?
So for reading, the red area is 2 or more grade levels below, which is another reason why in the younger grades, you can't get too much further below at pre-K. So when you're a 5th grader and you're reading at a 3rd or below grade level, you're in that red. So you might be, reading pretty well, but still really, just have some deficiencies. So that for literacy, the red section is approximately 2 or more grade levels below, and then yellow would be just a year below, or, about, I'm using some approximation. And then the green would be at grade level as compared to peers across the nation.
So I guess, sorry, then that triggers a follow-up question. So if I'm a parent, I see 1 year below or approaching, that's pretty easy to understand. Below, obviously, we know we need to do some work. But if you're proficient, that could be a pretty big gap, So if a kid is able to answer one question or misses just one specific question, that could potentially be the difference between approaching and proficient, or below and approaching. And so are we sure that the parents have a true picture of how their kid is performing to know, maybe I'm not overly worried about, if pushing the kid to read that extra book or whatever, are we sure that the parent is truly seeing how representative the kid is doing compared to what they should be?
The reports that are sent home for literacy break it down by those categories. So there is a score for phonemic awareness, a score for phonics, a score for vocabulary, and each of those areas, and it shows you whether it's a bar that says how close you are to that meeting expectation. So I can get you a parent report if that would be helpful, but it does break it down and make it, in our opinion, hopefully clear to the families about how close they are in each category and what's keeping them from being at grade level.
And I assume it's similar for math?
It is not yet. So that is an area that we are actively working on. That is something that we absolutely need to improve on, is ensuring that parents have an understanding of, so what does that 65% represent after quarter 1? What were the skills that were worked on, and how can I help my child from home? And so that is, we're actively working to build that in coordination with the revised standards and everything coming into next year.
I'm sorry, go ahead.
No, speaking at least from a secondary perspective, I've gotten the paper numerous times in the mail. I'm assuming it's the same because it's the CAPTI score. And there's a really illustrated bar graph, and on the back of the page, I believe it has specifically like this number of points were in this section, this number is proficient, this number. I at least found it relatively clear to understand.
I just wanted to say, when we were in a CNI meeting, I had mentioned this, like, from a parent's perspective, I find it more helpful if you are sending me home a worksheet and having me actually sit down with my child and do math facts instead of sending home a game. Because if you send me home a game, I'm probably not playing the game. So I need accountability, And I think that's what a lot of parents need. They need something being sent home. And I'm not talking about a huge amount of homework or anything like that, like 20 questions or something on a page for math facts. Just something like that is what I would recommend.
And that's a little bit more along the lines of what we're working toward for next year. It won't only be math facts, though.
Okay.
But that's what we're working to build out for next year is some additional, again, we know that it helps stick in students' long-term memory to be able to come back to things that they haven't seen in a while and recall some of those pieces as well, inclusive of math facts.
I was thinking exactly what Daryl asked. When I was in school, you had percentages sent home. And so it was very clear where you stood. And so I guess I'm with Daryl. I mean, are parents aware of exactly how their kid is falling in line? Or, because this chart wouldn't, if I saw a chart like this, you know, I might see yellow and 40, I don't know. Anyway, it was just something I thought about and you asked.
From a parent standpoint, I do get these sent home, and I think that it gives me more information than our current report cards.
All right.
Okay, so I want to start with, Mr. Burkett, something that you shared is that we have amazing teachers who work really hard and they are looking at data, they're looking at the needs of their students, and they are addressing needs and working to close gaps. We feel like we are a team up here, and our job is to help support our teachers and help support our principals. So I'm going to share a little bit about the way that we work together to support our principals. So each of our schools has, I'm sorry?
I said, I didn't realize we cut you off. I'm sorry.
No, it's fine. We have a good bit left. So at the elementary level and secondary, our school improvement plans are grounded in data. Schools create those plans based on the needs that they see within their data. We as a team then go in and we help and we support and look at where there are areas that they might need professional development, where are there areas that teachers might need additional support or coaching, where LTs may need additional leadership skills or something to better support them. Our plans are static, or not static. They drive what we do every day, and they drive what our schools are doing. So across the year, our content teams, all of us, math or science, social studies, special ed, our ML, we know that we cannot help support our schools unless we have a unified front, and we are working together to make sure that what we are saying is in alignment and we are supporting the needs of our schools. At the elementary level, we hold quarterly meetings, and those are tailored to each school's needs. So as a team, we go in, including always ELA and math, sometimes it's science, always special ed, sometimes ML, depending on populations and the needs within the building. And our purpose is really to partner with schools, to look at what their needs are, to analyze data, to set goals, to help them look at what targets they have already set for themselves as a school, and then how can we support? So sometimes that can be content teams coming in and doing coaching with classroom teachers. Sometimes it's with the LT. Sometimes it makes us come back and say, okay, we need this professional development in this area. So really trying to be a partner with the schools and help support whatever their needs are. Several quarterly meetings, we also work alongside to look at scheduling options. So especially in the past year, we've had quite a few schools that have transitioned into departmentalization or specialized. And really what that means is I might be teaching math for 5th grade, Carly would be teaching ELA for 5th grade. And so how does that look? How do you look at your data to determine Carly is the best ELA teacher? How do you determine who's going to teach what? And in some cases, you have some teachers that say, you know, I really like having my whole class. I feel like I can reach them differently. I can reach them better if I have them all day long. So we really kind of look at school needs. Who are the staff that are currently in place? How do the teachers feel about specialization or not specialization? What's the data showing us? And then what do the students need? We have some students that just don't do well with transitions. So in some cases, you might have 2 teachers that are specialized and one that's self-contained, and I just teach all of my ELA, math, science, social studies. I teach it all. We have started classroom lab visits in the past several years, and really what that does is it allows principals to walk into a classroom, to see the same teacher teaching. Our content team really sets us up. It's usually our district literacy lead teachers or math district, whatever, math lead teachers. So they are really our experts, and they are amazing, and it allows principals for us all to have the same conversation, to all see the same thing, to talk about here's what an amazing Tier 1 looks like, here's what an amazing Tier 2 looks like. The teachers often then are able to come in and have conversations. They're able to tell us why they grouped this small group together based on their data and based on student needs, and how within a 90-minute math block, including the 30 minutes of supplemental, that they are able to support the needs of their students. So ultimately, again, we work together. Our commitment is to schools. We know that the more that we are working together, looking at data, looking at student needs, and helping to support our schools, the better it is for our students.
Okay, we're going to shift gears a little bit to middle school. And we do have the same assessment. The CAPTE Read Basics assessment is used in literacy, and the math interims are used for the math in grades 6 through 8. So our literacy data is displayed here. We do have over 40% of our middle school students reaching or being proficient, with about 21% approaching and 37% below. So going with President Evans, your comment, what does the red stand for with the 2 or more grade levels below? Now we have multiple, so you could be an 8th grader reading at 6th grade and you would be in the red. So again, the expectations grow, and therefore we need to just increasingly provide support to fill those gaps. Comparison, last year we are slightly above. Last year we were just at 40.3% proficient, and in the red we were at 40% red. So we've decreased to 36%. So a 4% decrease in red and about a 2% increase in green, which is the direction we would like to go. So how are we supporting middle school? Very much in the same way. One key difference, the middle school schedule allows for built-in time to collaborate and to have job-embedded professional learning. So as you've heard before, our middle school teachers have the 90 minutes of planning, which provides 45 minutes that we can dedicate to job-embedded collaboration and professional development. And that's the time that the teachers look at the data, they determine a instructional routine that will support the students, they plan for that supplemental instruction, which again, even in middle school, we have 90 minutes of ELA, 60 minutes of core grade level instruction, 30 minutes for small group instruction with our supplemental instruction teachers and various supports. And in middle school specifically, looking forward to improvements in the area of writing. We know that even writing down to the sentence level, writing a strong sentence, and then writing paragraphs and essays will improve the reading and overall literacy for our students. And then to your point, Mr. Burkett, the focus on many of our middle school teachers share with us the need to better understand how to support ML students and students with disabilities in their core classes, and what are the best ways to support those students. That's continuous efforts for improvement.
When are they bringing cursive writing back?
Oh, we teach cursive writing. We have to cursive.
Do they?
Absolutely. We have explicit instruction in cursive writing and time to practice it. Absolutely.
So the schools receive this data personalized to each of the classrooms?
Yes.
So as they do job-embedded staff development, they can say, okay, you're having a lot of success. Is it because of the students? Is it because of your technique? Is it because of your, so it's really personalized per school.
Absolutely. And that brings another point. Our data system, our early warning system provides that data at the student level for all teachers who have those students. So our social studies teachers who have students, they can see their reading data and see how far away they are from grade level, or is their strength vocabulary, is their weakness writing? So down to those categories, they have that data at their fingertips that they can use in the collaborative planning to plan for the student needs.
That same thing's true in math. But so here on your screen, our data in 6th, 7th, and 8th grade math together, again, taking a look at our Washington County interim or benchmark assessments. Again, this is the average of 2 of 3 interims so far, and the percent of students demonstrating proficiency to date on grade level standards in the green, almost 40%. A pretty large group there, just below grade level, approaching at almost 38%, and close to 23% there below, with whom we need to continue to work to close those gaps here the rest of this year and as they prepare for high school. Again, that assessment is, focusing on the primary skills needed to be successful in algebra especially, and to get them ready for high school. And certainly teachers have common assessments by unit that they also use in between these to support figuring out what students need additional support with, to regroup students during that supplemental instruction time and support them there. So with that, supporting our students and teachers in middle school math, as Carly already mentioned, opportunities weekly for collaboration and job-embedded professional development. Our primary focus this year in secondary math has been around embedding instructional routines to support math discourse or discussion in class, that communication. Students need to think about math, talk about math, and be able to write about their reasoning, their justification, and their thinking. Just helps us overall be better problem solvers in general, mathematically or otherwise. So that has been one of our primary focuses in secondary math. Again, that supplemental instruction, as I mentioned, teachers are using both the interim assessments as well as common unit assessments to determine which students need extra support with what skills and when, as well as also determining when a student may need enrichment or be able to go above and beyond as well. And so lastly there, again, just looking forward as the Maryland math policy, looking forward to that next year with the revised standards. An impact on middle school for next year that we see is actually a reduction in standards in 8th grade in particular. We're excited about that. That will provide some additional just time for teachers and students to dig a little bit deeper with the math, and additional time to practice and really ensure that students have a deep understanding before needing to move and connect to the next topic. And then here I was where I wanted to bring in that next year we are working on a system-wide approach to sharing those ongoing math assessment results with families, including the key skills that their child's working on in school, how they can not only help their child at home, but also just truly partner with their school and their math teacher at school as well in supporting their child.
And how do we support administrators for student success in the secondary level? So similar to elementary school, our secondary school improvement plans are grounded in data and data analysis. Schools work collaboratively with different departments and stakeholders to create a living document that drives the ongoing work within our schools. In secondary level, we do have monthly council meetings where we meet with principals and content teams and departments to collaborate on topics and problems of practice, and our focus is to address the needs of secondary schools through data analysis, professional development, and teamwork. This collaborative approach models for principals strategies they can use with their own schools to promote consistent, aligned messaging and support continuous improvement. We collaborate with the STEMs and humanities teams here at Central Office bi-weekly to not only plan our council meetings, but also to align our planning for our monthly assistant principal meetings, lead teacher meetings, and case manager meetings. And this ensures we deliver a consistent message aligned to each leadership group, streamlining school improvement efforts and increasing student success at the secondary level. Similar to elementary school, we have lab visits, which involves a group of 4 principals who attend a professional development session with our content specialist at a selected school site. Principals work through the teacher's lesson materials and best practices with the content specialist using our HQIM resources. Principals then spend 45 minutes observing a classroom, followed by a debrief session with the content specialist and the teacher. This approach allows principals to observe our content lead teachers in the classroom during Tier 1 and Tier 2 instruction. The flexibility of the secondary schedule allows us to schedule classes as a single block 45-minute class or a double block 90-minute class. And in a 90-minute block class, students in ELA and math receive their 60 minutes, as you've heard throughout today's presentation, of Tier 1 instruction and 30 minutes of Tier 2 or supplemental instruction. During the job embedded professional development time that teachers have once a week with PD, and then they have 2 to 3 times where they're working with their department level team. Teachers work on lesson planning, analyzing and looking at the HQIM resource, and conducting assessment analysis using our 4A process, which includes assess, analyze, act, and adjust. And they also collaborate with our ML teachers, our special education teachers, and our supplemental teachers to plan for student success for lessons within the coming week. And at this time, we'll answer any additional questions that you may have for any of us.
You were just yelling them out as you
right.
went.
Right. They did a good job.
Going good? Very good. Well, we do thank you guys very much. I know it's not easy work that you guys do, and I know our teachers appreciate it, and we certainly appreciate the support you provide. So thank you for all you do.
Thanks.
All right, and with that, if no one else has anything for the good of the order, this meeting is adjourned.